Welcome back guys. Now in this video, let's discuss about the topic of menopause and hormone replacement therapy. Now to begin with, what exactly is menopause? Menopause means complete cessation of menses, or we can say that menstrual cycles in this female are completely stopped. So it's a permanent cessation of menses. Now how can we say that a female have attained her menopause? It's by amenorrhea. There is this woman who is of menopausal age group. Now she had amenorrhea for continuous 12 months. Now we can clearly say that she is into menopause. Please concentrate guys. Amenorrhea for 12 months. Okay, amenorrhea for 12 months in a menopausal age group woman. Now we can say that she is into menopause. Menopause is a retrospective diagnosis. Please concentrate here. It's retrospective diagnosis. It's an MCQ. Why it is a retrospective diagnosis? It's because now there is this woman who is of menopausal age group, and now she came to the clinic and now she is saying that she is having this amenorrhea for the last 1 year. That's 12 months of amenorrhea. From now I'm just checking into her past. So past 12 months of amenorrhea. So I'm checking her past data. So it's a retrospective diagnosis. True. Menopause is a retrospective diagnosis. Just like that, menopause is a clinical diagnosis. What does I mean by? There is this female and she is somewhere around 50 years of age. And now she came to the clinic and she is saying that she had this amenorrhea for 12 months. Enough. There is no need to do any further investigation. There is no need to do further laboratory studies. Now we can simply say, menopausal age group woman, she had amenorrhea for 12 months. It's very clear that she has attained her menopause. Simple. It's a clinical diagnosis. No need of further investigation. No need of FSH, LH levels. Okay. It is a clinical diagnosis. Well, what is the average age for attaining menopause? Worldwide it is 51 years and in India it is 47 years, which means most of the Indian females are more likely to get into menopause by 47 years of age. That's the average. The range can be somewhere around 45 to 50 years. Now, what exactly is premature menopause? Guys, the name itself, it's very clear. It's a premature menopause. Usually menopause is something happening around 50 years of age. But if there is this ovarian failure, menopause is nothing but the ovarian failure, which we will discuss in detail. If ovarian failure is happening even before 40 years, so we are calling it as premature ovarian failure. Premature ovarian failure means menopause in a woman who is not even 40 years. Okay, so less than 40 years. Menopause in less than 40 years age woman is known as premature ovarian failure. Now, what exactly is a delayed menopause? Very clear. Delayed. Menopause is getting delayed after 55 years. If a woman had her menopause after 55 years, it is called as a delayed menopause. After saying this, now please concentrate. This is what we have discussed. Now, let's see what exactly happens in menopause, or what is the physiology of menopause. Guys, during menopause, we all know that the ovarian follicles are getting completed. Even in the topic of anatomy of female reproductive tract and even in the topic of menstrual cycle, we have clearly discussed that in a female who is in her intrauterine life, okay, there is this female and she is in her mother's uterus. Now, intrauterine life, her ovaries are having almost 6 to 7 million follicles. But by the time of her birth, there are only 1 to 2 million follicles, and by the time she attains puberty, there are only 4 to 5 lakh follicles, which means the follicles are gradually getting decreased. Okay, as the age is getting increased, follicle count is getting decreased. By the time she reaches 50 years, all the follicles in her ovaries are completely got atrophied. Okay, there is atresia of the ovarian follicles. Now there are no more follicles. When there are no more follicles, what happens? We all know that the granulosa cells of the follicles are the ones which make the estrogens in the female. As the follicles are going down, the estrogen production from the granulosa cells of the follicles is not there. So, estrogen is decreased. Okay, well and good. Now, what about progesterones? Whenever there are no follicles, there is no chance of ovulation. Okay, whenever there are no follicles, what about the concept of ovulation? Okay, ovulation is not going to happen. Whenever there is no ovulation, there is no corpus luteum. Whenever there is no corpus luteum, there is no such thing as progesterone. So, no corpus luteum, no progesterone. So, at the end of the day, the one important point I want to put into your mind is, in a menopausal woman, the estrogens are going down as well as progesterones are going down. Whenever these hormones are not there, what happens? There is no concept of menstrual cycle. Why? Because in the topic of menstrual cycle, we have clearly discussed that estrogens are the one which makes the proliferatory changes in the uterine endometrium, and the progesterones are the one which makes the uterine endometrium more secretory. Whenever there are no estrogens and no progesterones, there is no concept of menstrual cycle. So what happens? There is no menses. Menstruation is completely ceased, and this is what happens in the menopause. Now after this, let's see what happens because of no estrogens and no progesterones. We have seen the estrogens are going down and progesterones are coming down. That's the reason why there is no menses. Apart from that amenorrhea, there are certain other conditions also. Let's concentrate now. Because of menopause, follicles are totally gone. Okay, by the time she attains menopause, follicles are completely gone. Now, whenever there are no follicles, the estrogen level is going down. We have discussed. But the exam question is that how much decrease? Estrogens are going down, but how much? The laboratory value will be somewhere less than 20 picogram per ml. See guys, this is a very important MCQ. Repeatedly they can ask you this. In a menopausal woman, the estrogen levels are less than 20 picogram per ml, and this is a diagnostic for menopause. See, we have discussed that menopause is a clinical diagnosis. No need to do all these laboratory studies. But if you want to know if you have performed a laboratory study in a menopausal woman, there you can clearly get that estrogen values are less than 20 picogram per ml. Now when estrogens are going down, what happens? The concept is that estrogens give negative feedback to FSH. Whenever the estrogens are there, FSH won't be there. Whenever the estrogens are going down, FSH levels increase. Now in our condition, in this menopause, as estrogens are going down, FSH start to increase. So please concentrate, FSH levels are more than 40 milli-international units per ml. It's a diagnostic for menopause. So FSH levels are increased how much? More than 40 milli-international units per ml. Now, all this FSH is going where? This FSH is getting excreted in the urine of this postmenopausal woman. So postmenopausal woman, estrogens are low, progesterones are low, FSH is elevated. All this elevated FSH, all this so much amount of FSH is getting excreted in the urine of this female. Now, from the urine of this female, FSH is getting extracted and used in the synthesis of human menopausal gonadotropin. So, what exactly is the human menopausal gonadotropin, guys? Human menopausal gonadotropin is nothing but the FSH which was extracted from the urine of postmenopausal women, and this human menopausal gonadotropin is used for ovulation induction. That we will discuss in the topic of infertility and all. For now, the important point to be kept in mind is human menopausal gonadotropin is nothing but high levels of FSH which is extracted from the urine of the postmenopausal female. Okay, now after this, because of decreased estrogen, what kind of symptoms a female will experience? The first symptom and the most common symptom are the vasomotor symptoms, which includes the hot flashes. A female is going to experience hot flashes. So what exactly are the hot flashes? We are going to discuss in the later slides. But for now, please keep this point in mind. The most common symptom that a female experience because of the decreased estrogens are the vasomotor symptoms, hot flashes, MCQ. Now after this, there can be activation of the osteoclasts in the bone. So that leads to bone resorption. That causes demineralization of bone, ultimately leading to osteoporosis. Yes, decreased estrogens, osteoporosis. Menopause, decreased estrogens, osteoporosis. Now, there can be atrophic or senile vaginitis. Why? Again, we have already discussed this. Estrogens are the one which keeps the vaginal epithelium healthy, or I can say estrogens maintain vaginal epithelium, estrogens maintain vaginal flora, or estrogens maintain vaginal pH. So to maintain the vaginal environment healthier, you need to have proper amount of estrogens. Whenever the estrogens are going down, there can be atrophic changes which are happening in the vagina. So that causes to atrophic vaginitis. We'll discuss in detail, but for now, please keep this point in mind. Because of loss of estrogens, a female is going to experience vasomotor symptoms like hot flashes. There can be activation of osteoclasts in the bone that leads to osteoporosis. Atrophic changes are happening in the genitourinary system, leading to atrophic vaginitis or senile vaginitis, and there is a risk of coronary artery disease. Okay, estrogens are going down. Now the female is at a risk of coronary artery disease. Why she is at a risk of coronary artery disease? Now we will see. Guys, please concentrate. What estrogens are doing in a normal reproductive age group woman? Good amount of estrogens are there, and these estrogens are acting as a cardioprotective agents. Why they are cardioprotective? Because they increase the HDL cholesterol, which is a good cholesterol. So estrogens increasing the good cholesterol. So they are cardioprotective. But after menopause, what's happening? After menopause, estrogens are going down. Whenever estrogens are going down, HDL cholesterol will also goes down. Whenever HDL cholesterol is going down, what happens? The cardioprotective action is lost. So that now this female is at a risk of developing coronary artery disease. Okay. So after menopause, there is a risk of coronary artery disease. So what is the best predictor of coronary artery disease in a menopausal woman? In a menopausal woman, if HDL levels are going down, she is at a risk of coronary artery disease. So what is the best predictor? It's the HDL levels. HDL levels are the best predictor. Now, guys, let's come back to the topic. So we have seen what and all the events which are happening because of decreased estrogens. Now let's see what and all the events which happens because of decreased progesterone. Why there is decreased progesterone? Why? Because no follicles. Whenever there are no follicles, there is anovulation. Whenever there is anovulation, there is no corpus luteum. Whenever there is no corpus luteum, there is no progesterone. Whenever there is no progesterone, okay, progesterone levels are going down, there is no negative feedback on luteinizing hormone. Just like estrogen. Estrogen give negative feedback to FSH. Just like that, progesterones give negative feedback to LH. So whenever progesterones are going down, LH is going to increase. Why? Because there is no negative feedback from the progesterone. LH starts to raise. So LH levels are more in a post-menopausal age group woman. Okay. Now, so whenever there is no progesterone, there is no concept of menstruation at all. So the female is going to have amenorrhea. Well, now please concentrate, guys. When we are discussing about menstrual cycle, we have discussed that there is this follicle with the primary oocyte surrounded by the granulosa cells, which makes the estrogen, and the granulosa cells are in turn surrounded by the theca cells, especially theca internal cells, which makes the androgens. Now, what's happening during menopause? During menopause, there is this ovarian failure happening. Ovaries are failed in their duty. They are no longer producing any hormones, no estrogen, also no androgens. So the ovarian androgens, whatever are getting produced from the theca cells, they are not getting secreted. So androgen levels will also go down. True. Androgens level goes down, estrogen levels goes down, progesterone levels goes down, but FSH levels increases, LH level increases. As androgens are going down, libido, sexual drive in this female, okay, the desire to have sex is going to decrease in this post-menopausal age group women. Okay, now, so these are, this is just like, what and all the events which are happening in the menopause. Now, after this, let's see few more changes, okay, few more changes what we can see in a post-menopausal age group women. Guys, there can be a mood changes, okay, they can ask you all of the following changes can be seen in a post-menopausal age group women, except there can be mood changes, there can be this mood liability. Sometimes these female feels so depressed, so alone, sometimes they feel so much anxious, they can easily get irritated. So mood changes because of the hormonal fluctuations. Till now there is good amount of estrogen. Now suddenly estrogens are going down. So this can impact on the central nervous system of this female. So because of these hormonal changes, now she can have this mood liability. True. Now there can be sleep changes. Most of the times they will have this sleepless nights. Okay, insomnia. They will become insomnia. And there can be skin changes as well. Why skin changes? Because estrogens are maintaining proper hydration of the collagen. Okay, whatever the collagen which is present in the skin, that will be kept in a good state by the estrogens. So whenever the estrogens are getting down, the quality of the collagen, or I should say the hydration of the collagen, is not properly maintained. So now the skin starts to show wrinkles. It's true, right? If the female is getting older, she will start to have the wrinkles. It's very much common sense. So wrinkles are something, skin changes, which you can expect in a post-menopausal age group woman. True. And you can see facial hair, not in everyone, but in some group of women, because of unopposed adrenal androgens. I'm talking about adrenal androgens. These adrenal androgens, they are not having any opposite effect by the estrogens. So now these unopposed adrenal androgens now can start the development of facial hair, especially on the chin and the lip. Okay, so yes, it is possible. Now you can see in these females, okay, these are the females who are getting older. Now you can see that there are these chin hairs, and even here you can see these lip hairs. Yes, it's possible. Okay, now, so there can be hoarseness of the voice, and there can be decrease in the breast size. Guys, this is MCQ. Now they can ask you something like this. There is decrease in the breast size in a postmenopausal woman. It's a true statement. Why? The decrease in breast size is because of decreased estrogens or decreased progesterones. The answer is both. We know that the estrogens are going to act on the ductal component of the breast, and progesterones are something going to act on the glandular part of the breast. So whenever estrogens are going down, the ductal proliferation is not going to happen, and whenever the progesterones are going down, the glandular part is getting affected. So because of menopause, both estrogens and progesterones are going down. That's the reason why there is this atrophy of the breast. Okay, there is decrease in the size of the breast, and there can be pelvic organ prolapse. This is something very much important. Usually pelvic organ prolapse, or I can say that uterocervical prolapse, is something happening after delivery. After delivery, because of some faulty instrumentation or because of prolonged second stage of labor, whatever might be the reason. Usually this uterocervical prolapse is something which is seen after deliveries. But these females are not the females who are giving the delivery. This age group is something totally far away from that age group. Now, why there is this uterocervical prolapse or uterine prolapse seen in the menopausal age group women? It's because she is old, right? She is getting old. Whenever she is getting old, her pelvic diaphragm, the major support, her pelvic diaphragm, the levator ani muscles, they are getting weak. The tone in these muscles, the levator ani muscles, the tone is getting lost. And also, whenever she is getting old, her ligaments are so much torn. Okay, that main important ligaments are there, right? The triradiate ligaments, the pubocervical, the uterosacral ligaments, the cardinal ligaments, they are getting so much lax. Okay, there is no proper strength from these ligaments. So by the time she attains her menopause, there is weakening of the supports. There is weakening of this pelvic diaphragm as well as the ligamentous supports. So there is a chance that she can have pelvic organ prolapse. Okay, yes. So after this, let's talk some important concepts about the hormone replacement therapy. Now let's talk about hormone replacement therapy. Guys, what exactly is this hormone replacement therapy? We have already discussed that during her menopausal age, she is going to have a lot of symptoms like hot flashes, osteoporosis, atrophic vaginitis, there is increased risk of a cardiovascular problem. Now, in order to treat that symptoms, we can simply replace the estrogens. Am I right or not? All the symptoms whatever she had are because of loss of estrogens. So in order to treat her symptoms, we can simply replace these estrogens. So that's what we are going to do in the hormone replacement therapy. So it's just simple replacement of the lost estrogens in a postmenopausal female. Okay, well and good. So what kind of hormones we are going to give to this female? Guys, the drugs which we are going to use in HRT are 17-beta estradiol. We all know it's estradiol, right? Which is nothing but estrogen. So 17-beta estradiol can be given every day 1 to 2 milligram. Guys, I want you to know this value 1 to 2 milligram. Why I am saying 1 to 2 milligram? Because 1 to 2 milligrams of estrogen per day is high dose of estrogens. As I am giving high dose of estrogens, there is a risk of endometrial cancer. So, if I am talking about hormone replacement therapy, I will be all the time talking about the endometrial cancer. Why? Because HRT poses a high risk of developing endometrial cancer. You are giving high dose of estrogens to this female. So these high doses of estrogen can cause endometrial proliferation, and that endometrial proliferation can change into endometrial hypoplasia, and that endometrial hypoplasia can change into endometrial cancer. True. Okay. So we are giving estrogen in the form of 17-beta-estradiol 1 to 2 mg per day. Or either you can use a conjugated form of estrogen known as conjugated equine estrogen. So these are the estrogens from the horse, equine estrogens, which you can give 0.625 milligrams per day. The important point is that, guys, if you are using these estrogens in a female who have an intact uterus, there is this menopausal age group woman, you are using estrogens to treat her symptoms. Now, if you are only using these estrogens, what they do? They are going to act on the uterus. They are going to make the uterine endometrium hypoproliferated, and this hypoproliferated uterine endometrium can turn into cancer. So, in order to counteract the effects of estrogens, what you can do is adding progesterones. So, if you use estrogen plus progesterone, or I should say, if you give estrogen plus progesterone, the estrogenic action is counteracted by the progesterone, and this progesterone doesn't allow the endometrial hypoplasia. Rather, these progesterones will bring the atrophic changes in the uterine endometrium. True, progesterones brings the atrophic changes in the uterine endometrium if you are giving it continuously. Yes, true. So, in a female who have intact uterus, you should always give estrogens plus progesterones. The progesterone which you are going to use is a micronized progesterone. Okay, so micronized progesterone 200 milligrams per day. In a month, at least 12 days you have to give. Okay, in a month, at least, this is the question, in the month, at least 12 days of progesterones are needed along with estrogens in order to prevent the endometrial hypoplasia and cancer. Okay, or you can use one drug which have both estrogenic as well as progesteronic action, that is tibolone. Rather than giving estrogen separately and progesterone separately, you can give this drug which is a tibolone, which have estrogen plus progesterone, also androgenic actions. Okay, these are the drugs which are given under hormone replacement therapy. Estrogens should always be given along with progesterone if a woman have intact uterus. Okay, now the important point to note here is that, guys, I have said you, if I am talking about hormone replacement therapy, every time I will be talking about the endometrial cancer. Hormone replacement therapy, estrogens plus progesterones, endometrial cancer. Guys, please try to understand, hormone replacement therapy is nothing but estrogen plus progesterone, also oral contraceptive pills. Oral contraceptive pills also estrogen plus progesterone. If I am talking about HRT, endometrial cancer, but I will never discuss about endometrial cancer while I am talking about OCPs. OCPs also same thing, right? Estrogens plus progesterones. But OCPs will never increase the risk of endometrial cancer. Why? Why? Because the dose in OCPs is comparatively less. OCPs have less amount of estrogen. So these less amounts of estrogen are not going to act on this endometrium and cause endometrial hypoplasia and endometrial cancer. In turn, the OCPs are going to give protection against endometrial cancer. Okay, please keep this point in mind. OCPs protect against endometrial cancer. Why? Because these are very, very low doses. Hormone replacement therapy is going to increase the risk of endometrial cancer. True. Okay, so these are very important points. Now, at the end of the day, the important point to keep in mind is, if uterus is intact in a menopausal woman, you are trying to treat her symptoms by giving the replacement of the hormones, and this female have an intact uterus, so you are going to give estrogens along with the progesterones. What if uterus is absent? If uterus is absent, there is no such thing as endometrium. If there is no such thing as endometrium, there is no possibility of endometrial cancer. So you can simply use estrogens alone. Okay, in a female with absent uterus, you can use estrogens alone. But there are some special conditions where the female have undergone hysterectomy. Okay, she, because of some reason, whatever might be, she have undergone hysterectomy, uterus is not there. Still, you choose to give estrogen along with progesterone. You understand the concept, right? If uterus is absent, there is no need to give progesterone. But there are certain conditions where uterus is not there, but still you choose to give estrogen along with progesterone. So what are those conditions? Concept, guys, uterus is absent, but if a female had a history of endometriosis, okay, she is having endometriosis, or she had previously had CA endometrium, she had this endometrial cancer, and that's the reason why her uterus was removed, hysterectomy. Okay, hysterectomy has performed because of the CA endometrium in this condition. Or endometrioid variety of ovarian cancer or supracervical hysterectomy. These are the 4 conditions where the uterus was removed, still you choose to give estrogen along with the progesterone. They can ask you the questions. Okay, no need to go in detail about it. Simple thing, uterus present, both estrogen and progesterone. Uterus absent, only estrogens. Exceptions are supracervical hysterectomy, endometrioid variety of ovarian cancer, endometrial cancer, endometriosis. Okay. Well, why? Because all these conditions are estrogen dependent conditions, right? Am I right or not? Yes, they are estrogen dependent conditions. So if you are simply giving estrogens, these estrogens can aggravate these conditions, or these estrogens whichever you are giving right now, they can cause a recurrence of any one of the following. So to counteract the effects of estrogen, you are also giving progesterone. That's the concept. Okay. Well, at the end of the day, one important point is, in hormone replacement therapy, if a female is having intact uterus, now she is at a risk of CA endometrium. So that's the reason why you choose to give estrogen along with progesterone. Okay. Well, now let's see what are the indications of hormone replacement therapy. So what are the problems which are present in this menopausal age group women? Because of loss of estrogens, there are these hot flashes, vasomotor symptoms we have discussed, right? The most common menopausal symptoms are hot flashes. Almost 85% of the women are going to experience these hot flashes. Okay. Now the indications are severe hot flashes. Okay. So severe hot flashes in the sense that she is unable to bear, like these hot flashes are interacting or interfering with the quality of her life, or these hot flashes are interfering with her sleep patterns. Severe hot flashes. Wait, what exactly are these hot flashes? The name itself is a hot flash. Now she is going to experience intense heat. Okay, for a moment of time, she is going to have a sudden increase in the heat in her body with too much amount of sweating. Flushing is there, redness of skin is there, and she has this palpitation. She becomes more anxious, and now she is highly irritable. She is going to show so much anger. So this hot flash is going to last for a few minutes, and these hot flashes are going to come to this woman maybe 5 times a day, 6 times a day, 7 times a day, depends on. Okay, this can vary from female to female. Important point, sir. These hot flashes most frequently occurs during the night. These hot flashes are because of estrogen withdrawal, because of sudden estrogen loss. Okay, because of sudden estrogen loss during the time of a menopause, these hot flashes are coming, and these hot flashes most of the time they coincides with the LH surge. We have discussed, right? LH surge in the menstrual cycle. Like that LH is going to release in the form of pulses. So whenever there is this pulse, now she is going to have this hot flash. Okay, well and good. Now hot flashes are nothing but intense heat experience with sweating, redness of skin and palpitations. The female become more anxious, irritable and getting so much anger. Now if she can't able to manage with this, or if she is unable to bear these kind of symptoms, then we can use hormone replacement therapy. What exactly is hormone replacement therapy? Nothing but estrogens, right? So now let's see what are the drugs which are used to treat the hot flashes. One important MCQ from the entire chapter of menopause. This is the one question. What is the treatment of hot flash? The best treatment, the first line treatment is estrogen therapy, which is nothing but hormone replacement therapy. Hormone replacement therapy is the first line treatment for hot flashes. True. Guys, Other than this estrogen therapy, you can use a Tibolon, which is nothing but estrogen, progesterone, also androgen, or you can use oral contraceptive pills, which are also nothing but the estrogens and progesterones. Either you can use these hormonal drugs, okay, whatever here I have highlighted in blue color, they are the hormonal drugs. Estrogen, the Tibolon, OCPs, they are nothing but estrogens and progesterones. Or you can also use certain non-hormonal therapies or non-hormonal drugs. What are they? Selective serotonin receptor inhibitors like fluoxetine, paroxetine. Why we are using selective serotonin receptor inhibitors? We will discuss. Please, for now, please keep this one point in mind. Apart from hormonal drugs, you can also use non-hormonal drugs like fluoxetine, SSRIs, clonidine hydrochloride, gabapentin, pregabalin, isoflavone, soy products, vitamin E, all of them can be used. Why I am saying all this list? It's because they can ask you something like this. All of the following can be used in the treatment of hot flashes, except, so you should know what and all the drugs which are coming into play for treating the hot flash. Now, wait a minute. You can ask, if there are these good drugs like estrogen therapy, if you are saying like estrogen therapy or hormone replacement therapy is the best, then why we are using these other kind of non-hormonal drugs? It's because not all the females can take hormone replacement therapy. There are some contraindications for the hormone replacement therapy, right? Certain females with certain disabilities or with certain conditions, they are not supposed to take hormone replacement therapy. So for those females, we can use these non-hormonal drugs. Or see, this female is having so much amount of hot flashes, severe hot flashes. Now, even if I choose to give this hormone replacement therapy now, it will take almost a month to decrease her symptoms. It takes almost a month. So what about this 1 month? How to decrease her condition? How to decrease her symptoms? It's by giving the non-hormonal drugs which are used for acute management. Okay, so non-hormonal drugs for acute management and non-hormonal drugs for those females where estrogens are contraindicated. So what are the contraindications for hormone replacement therapy? At the end of the lecture, we will discuss. So in which conditions you are not supposed to give hormone replacement therapy. That's a later topic. But for now, let's continue. Guys, the non-hormonal drug which can be used for treating hot flashes, we have discussed SSRI, selective serotonin receptor inhibitors, fluoxetine. Why we are giving that? It is because, please concentrate, it is observed that in these females, in this post-menopausal age group females, serotonin levels are low. So what you have to do? You have to increase the serotonin levels. SSRIs will do that. Okay, selective serotonin receptor inhibitors. The reuptake is inhibited, so in the synapse, serotonin levels will be increased. So, very important point is serotonin levels are shown to be low and norepinephrine levels in a postmenopausal woman, the synapses, they are shown to be high in levels. Important points to keep. Okay, well, we have completed the topic of hot flashes and its treatment. Now let's discuss some important points about the osteoporosis. Guys, we have discussed because of decreased estrogens, the osteoclasts are getting activated and there is this osteoporosis. Now, let's see in detail what exactly is happening in the bone. Normal physiology of the bone first. Normally, in the bone, there are these cells called as osteoblasts, which are the bone forming cells. Okay, they make the bone. Now, these osteoblasts are going to make rank ligand. Osteoblasts producing rank ligand. Okay, this rank ligand is going to act on the osteoblast. Whenever rank ligand binds to osteoclasts, now osteoclasts are getting activated. Now these activated osteoclasts, what they will do? They will do bone resorption. They will cause a demineralization of the bone. So there will be osteoporosis. Question is that osteoclasts are activated by rank ligand and rank ligand is produced from osteoblast. So I can clearly say the osteoclastic activity is regulated by osteoblasts by producing the rank ligand. Now here comes the role of estrogens. But what exactly these estrogens are doing? We all know that estrogens are osteoprotective. In a young female who is in somewhere in her 20s and 30s and 40s, estrogens are in good amount. These estrogens are going to act on the bone marrow stromal cells. Now these stromal cells, under the effect of estrogens, they are going to make a protein called as osteoprotegrin. This osteoprotegrin is going to act as a decoy receptor. Okay, you all know what is a decoy, right? For example, what you can see here is a decoy. Decoy is a trap. If I just want to go for fishing, I just need to put a trap. So this is a decoy. The osteoprotegrin is going to act as a decoy. How? Please concentrate. Usually, rank ligand should bind with osteoblast. Okay, rank ligand should have to go and bind with the rank receptor on osteoblast. But whenever there is this osteoprotegrin, this rank ligand will come and bind with the osteoprotegrin. So that rank ligand will no longer go and bind with the rank receptor on osteoclasts. Okay, so what happens? Estrogen simply take out the rank ligand from getting bind to its receptor. Whenever there is no rank ligand, osteoclasts are not activated. Whenever osteoclasts are not activated, the bone resorption is kept in check. So bone resorption is not happening. Bones are not getting demineralized. So at the end of the day, one thing is very clear. Estrogens help in production of osteoprotegrin. Osteoprotegrin inhibits the rank ligand. Whenever the rank ligand is inhibited, resorption of bone will also inhibit. Now what happens in menopause? Menopause, estrogens are going down. Whenever there are no estrogens, there is no such thing as osteoprotegrin. Whenever there is no osteoprotegrin, rank ligand is not inhibited. Rank ligand, now it can go and bind with the rank receptor which is present on the osteoclast. Now osteoclasts are getting activated. So whenever osteoclasts are activated, there is bone resorption. Whenever there is bone resorption, what happens? Bone is getting demineralized. Bone mineral density is going to decrease. That makes the bones brittle so that they will become fractured. So at the end of the day, one important point is after menopause, osteoprotective effect of estrogens are lost after menopause. So that's why a female can have easy fractures. Here comes the question. What are the most common fractures? The most common fractures in a postmenopausal aged woman are vertebral compression fractures, followed by wrist fractures, distal radial fractures, as the Pully's fracture, hip fracture, femoral head fractures, right? So, what are the most important fractures, guys? It's the vertebral compression fractures are the most common fractures, MCQ. Okay, they can also be wrist fractures, Pully's fracture, hip fracture, femoral, head, okay, femoral head fractures, femoral neck fractures, all these are possible. So, how can we know that a female is having osteoporosis? See, there is this female of menopausal age group. Now, she came to the clinic and now she is saying that I'm having these bone pains, okay, I'm having this joint pain. Now I'm suspecting that she might be having osteoporosis. She have developed osteoporosis. How can I know that she have developed osteoporosis? For that, I have to do a scan known as DEXA scan. What exactly this DEXA scan is doing? DEXA scan measures the bone mineral density. It measures how good the bones are, okay, how brittle the bones are. Like, it just simply sees whether the mineral density in the bone is good or not. What exactly is DEXA? Dual energy X-ray absorptiometry. Dual energy X-ray absorptiometry. No need to remember the full definitions. But to know whether the bones are good or not, the scan which you are going to do is the DEXA scan. Where you are going to do the scan? The DEXA scan is performed at lumbar vertebra. Okay, lumbar vertebra or hip. Especially these regions which are more prone to fractures, you can do the DEXA scan, and the value, whatever the result you are going to get, right? If the results are somewhere minus 2.5 standard deviation or even below that, okay, you are just simply seeing the results. If her results are coming somewhere at the range of minus 2.5 standard deviation or even below that, she is having osteoporosis. The diagnosis is established that she is having osteoporosis. Now you have to treat her. How you are going to treat the hot flashes? The first line drugs are hormone replacement therapy. You are just simply replacing the estrogens. Now, how you are going to treat osteoporosis? Now let's discuss that. The drugs useful in the osteoporosis, the first line drugs are bisphosphonates. Bisphosphonates are the first line drugs. Please take this point. The first line drugs used in osteoporosis are not just simply the hormone replacement therapy. You can use hormone replacement therapy, but the first line drugs are bisphosphonates. Examples of this bisphosphonate are alendronate, zoledronate, pamidronate, residronate. Okay, there are all these drugs, right? So, alendronate, ipamidronate, these kind of drugs. What exactly they are going to do? See, if you take these bisphosphonates, these bisphosphonates will be simply eaten up by the osteoclasts, and these bisphosphonates cause the apoptosis of osteoclasts. Now, all these osteoclasts, now they are getting apoptosed. Whenever osteoclasts are getting apoptosed, is it good, right? Yes, that's good. Why? Because whenever there are no osteoclasts, no bone resorption. So, bone resorption is decreased. That's what we want here. So, that increases the bone mineral density again. Resorption is decreased. So, bone formation. Okay, on the other hand, the osteoblasts are making the bone, but there is no bone resorption. That's what we want here. Okay, very good. But what are the side effects of this bisphosphonate? The side effects are something related to the GIT. Okay, gastritis can be there, esophageal irritation, esophagitis, esophageal perforation. Sometimes there can be osteonecrosis of jaw. Okay, the rare complication of bisphosphonates are osteonecrosis of jaw, and some of few important points are like whenever the female is taking these bisphosphonates, she should be well hydrated. She should have to take this bisphosphonate with lots and lots of water, and she shouldn't lie down immediately after taking these bisphosphonates. At least for half an hour, she shouldn't go lying down position. These are some important points. Other than bisphosphonates, we can also use the hormones, estrogens, in the form of raloxifene. Okay, raloxifene can be used. What exactly is this raloxifene? Raloxifene is a selective estrogen receptor modulator. It's a SERM group of drug. Okay, SERM, SERM, selective estrogen receptor modulator. What exactly is a selective estrogen receptor modulator? Which means in selective places, in some places of the body, it is acting like estrogen. But in other places of the body, it is acting anti-estrogenic. Now, where do we want estrogen right now, guys? We want estrogenic action at the level of bones. So, raloxifene is acting like estrogen on the bones, and it is acting anti-estrogen on the breast and endometrium. Is it good? Yes, absolutely good. Why? Because now this is menopausal woman. If I am simply giving estrogens, these estrogens can cause endometrial cancer and breast cancer, right? But the raloxifene, whatever I am giving, this raloxifene is estrogenic only on the bones. But on uterus, on breast, it is anti-estrogen. So there is no estrogenic action on the uterus and breast. So there is no risk of endometrial cancer or breast cancer. Important point. Raloxifene does not increase the risk of endometrial cancer and breast cancer. True. Now the question is, this is estrogen, raloxifene, estrogen. Can I use this raloxifene for treating hot flashes? Have we ever discussed in the topic of hot flashes raloxifene? No. Why? Why we shouldn't use? Why? Because raloxifene have very bad side effect, which is hot flashes. So you should never use the raloxifene for hot flashes. MCQ. Okay, this is a very important MCQ. Raloxifene should never be used for treatment of hot flashes. Rather, raloxifene is a contraindication for hot flashes. Okay, now we have completed the raloxifene. After raloxifene, let's discuss a few more important drugs which can be used for the treatment of osteoporosis. Guys, the next important drug is the teriparatide. Okay, so what exactly is this teriparatide? Teriparatide is a recombinant parathyroid hormone. It's a recombinant parathyroid hormone which can be used for treatment of osteoporosis. Now, in physiology, we have studied that parathyroid hormone is going to act on the bones, activate osteoclasts so that there will be bone resorption. It increases the blood levels of calcium. That's what we have studied, right? Parathyroid hormone from parathyroid glands is going to act on the bones, activating osteoclasts, and that's going to cause bone resorption. So ultimately calcium levels are going to increase. That's what we have studied. But now in this condition where there is already osteoporosis, why we are using teriparatide, which is a parathyroid hormone derivative? It's because now we are using this parathyroid hormone analog in pulsatile doses. If you are giving this teriparatide in pulsatile doses, okay, little by little, every regular intervals, Now this teriparatide is shown to activate the osteoblasts. So whenever the osteoblasts are activated, there will be bone formation. That's what we want here in the condition of osteoporosis. So that's how teriparatide works. After teriparatide, let's discuss about denosumab. Guys, denosumab, MAB, monoclonal antibody. So denosumab is a monoclonal antibody which is going to inhibit the rank ligand. Yes, rank ligand is going to act on the rank receptor which is present on the osteoclast. We have discussed the physiology, entire physiology we have discussed. If you inhibit the rank ligand, that's going to be something good. So this rank ligand is now getting inhibited by denosumab, and this can be given subcutaneously, treatment of osteoporosis. Good. Now after denosumab, the last important drug which we use is the strontium renalate. One important point about the strontium renalate is most of the drugs which we will use for treating osteoporosis, either they will activate osteoblasts or they will inhibit osteoclasts. One of the function they will do. But strontium renalate is one drug. It's having two hands. With one hand, it's going to activate the osteoblasts, and with other hand, it's going to inhibit the osteoclasts. So one drug which activate and inactivate both these cells, osteoblasts and osteoclasts, is nothing but the strontium renalate. So all these are the important drugs. Please keep that point in mind. The honorable mention, one of the important drug is there, that's calcitonin. Okay, even this calcitonin can be used for treatment of osteoporosis. Okay, still it's a controversial drug. You can use it for treatment of osteoporosis. We all know that calcitonin is produced from the parafollicular cells of the thyroid gland. It's going to increase the blood levels of calcium, and this calcium can be used by the bone for formation of a new bone. So calcitonin can be used. Okay, now after this, now we have completed hot flashes and its treatment. We have completed osteoporosis and its treatment. Now let's talk about atrophic changes which are happening in the genitourinary system. After menopause, do you know what happens? There will be genitourinary atrophy. The entire genital system and the urinary system, they will start to undergo atrophy. Why? Because there are no estrogens. Estrogens are maintaining the genitourinary system. So whenever the estrogens are going down, because of these atrophic changes, a female can experience dyspareunia. What exactly is this dyspareunia? Dyspareunia is nothing but painful coitus, right? Now she is going to have a very much pain whenever the penetration is happening. Why? Because there are no estrogens. Whenever there are no estrogens, there is this atrophy of the vaginal epithelium. There are this atrophic vaginitis happening. Whenever there are good amount of estrogens, these estrogens are going to act on the cervical mucosal glands, and there is proper amount of mucus secretion into vagina from the cervical glands under the effect of estrogens. Whenever there are no estrogens, the cervical mucus production is lost. So whenever there is no mucus in the vagina, there is no lubricant action. So the penetration becomes more painful. There is this dyspareunia because of the atrophic vaginitis and decreased mucosal secretion. Okay, cervical mucosal secretions. And there can be postcoital bleeding. Yes, there is this atrophic changes are happening, right? Because of this painful coitus, she may have postcoital bleeding also. And postmenopausal bleeding. What exactly is this postmenopausal bleeding? She have attained her menopause. Okay, and now there is bleeding from the genital tract. This is postmenopausal bleeding. This postmenopausal bleeding might be because of CS cervix also, whatever. But here, usually, this postmenopausal bleeding is because of atrophic endometritis. Even the endometrium inside the uterus, it is undergoing atrophic changes. Okay, so because of that, there can be postmenopausal bleeding, and there are chances of vaginal infections in this menopausal age group women. The question is why? Why there are chances of vaginal infections? No estrogens, we know. Menopause, no estrogens. Whenever there are no estrogens, the vaginal flora is not maintained, which means the lactobacillus in the vagina, they are not maintained. To have a good amount of lactobacillus, you need to have a good amount of estrogens. Whenever there are no estrogens, lactobacillus are gone. Whenever the lactobacillus are gone, lactic acid production inside vagina is lost. Whenever there is no lactic acid, there is increase in the pH. Whenever there is lactic acid, there is low pH, acidic pH. Whenever the lactic acid is gone, the environment inside vagina will become more alkaline. So this alkaline environment favors the development of bad bacteria that can cause bacterial vaginosis. Okay, and this bacterial vaginosis can further transform into pelvic inflammatory disease also. True. So there are chances of vaginal infections due to increased pH. Well, so how we are going to treat? How we have treated hot flashes, guys? The first line therapy for hot flash is hormone replacement therapy or the estrogen therapy. How we have treated osteoporosis, guys? The first line therapy is bisphosphonates. You can also use hormone replacement therapy, but the first line therapy for osteoporosis is bisphosphonate, alendronate, zoledronate, formicolate, those kind of drugs. Now, how to treat this atrophic vaginitis? Okay, the vagina is undergoing total atrophy. Now here, you can apply local estrogen creams. We are not giving estrogens systemically, rather we are giving estrogens the topical form. So the treatment is topical estrogen creams. If she is having painful coitus, she can also use lubricants. Okay, lubricants along with the topical estrogen creams are the treatment for atrophic vaginitis. And vaginal pH during menopause becomes alkaline or pH increases. Yes, we have discussed. Now after this, let's see what are the risks of hormonal replacement therapy. Hormone replacement therapy is nothing but giving estrogens, right? Estrogen. Now these estrogens can act on uterine endometrium, and this uterine endometrium can undergo hypoplasia and cancer. So giving HRT predisposes the woman for developing endometrial cancer. True. Estrogens can act on the breast, so they can cause breast cancer. True. Estrogens increases the clotting factors. Normally in the body, there is a balance between clotting factors and anti-clotting factors. But estrogens, what they will do? They increase the clotting factors. Whenever it increases the clotting factors, they favor more coagulation to happen. They favor more clotting to happen. So abnormal clotting, thrombus formation that can dislodge and form embolus. So thromboembolism that can cause stroke. So taking HRT keeps the woman at a risk of thromboembolism and stroke. Now, these estrogens, especially after menopause, is shown to increase triglyceride levels. Okay, so because of this abnormal increase in triglyceride level, there can be a risk of coronary artery disease. Okay, now these estrogens can also cause, these hormone replacement therapy can also cause these gallstones and polycystitis. So all these are the risk because of hormone replacement therapy. Now after this, let's see what are the contraindications for hormone replacement therapy, which means in which conditions you should never ever think about giving hormone replacement therapy for a woman. The main contraindications are undiagnosed vaginal bleeding. There is this female, now she is in her menopause. Now you are thinking to give hormone replacement therapy to her. Upon taking history, upon doing physical examination and all, you found to know that she is having undiagnosed vaginal bleeding, which can be because of endometrial cancer. So if vaginal bleeding is undiagnosed, still under evaluation, no, never give hormone replacement therapy. Why? Because this undiagnosed vaginal bleeding might be because of endometrial cancer. Who knows? Don't give. If there is history or active breast cancer, don't give. History or active endometrial cancer, don't give. All these are logics. If she is having endometrial cancer, you are giving estrogen therapy, what will happen? You are aggravating the condition. You are going to kill her, right? So in these conditions, don't give hormone replacement therapy. If she is having history of thromboembolism or stroke or coronary artery disease, don't give estrogen therapy or hormone replacement therapy. Why? Because we have already discussed that estrogens can increase clotting factors and that can predispose to thromboembolism. Now, if a female is having active liver disease or gallbladder disease, no HRT. Why? See, you are giving high amounts of estrogens. These estrogens should be metabolized in the liver, right? You are giving estrogens, and these estrogens must undergo metabolism inside the liver. Now, what if she is having active liver disease? Now, her liver is unable to break down these estrogens. So what happens? Estrogens are going to stay in the body for longer duration, and these estrogens can show side effect, abnormal side effects. These estrogens can go and act on breast, they can go and act on the endometrium and can cause cancers. So, active liver disease or gallbladder disease, no estrogens because metabolism doesn't happen. And if a female is having a history of transient ischemic attack, which is nothing but because of a stroke, okay, so in these conditions never give hormone replacement therapy. Okay, these are the contraindications. One important note is that a female with hypertension, okay, a female with a history of hypertension or diabetes mellitus. Hypertension and diabetes mellitus per se are not the contraindication. Mild hypertension, normal diabetes mellitus, controlled sugar levels, they are not the contraindication MCQ. They are not the contraindication for hormone replacement therapy. Specifically, if they mention something like this, uncontrolled hypertension, then you are not going to give these estrogens. Or they mention diabetes mellitus, uncontrolled sugar levels, okay, severe diabetes mellitus with associated vasculopathies. If they are saying so much about diabetes mellitus or hypertension, then it's a contraindication. But normal hypertension, diabetes mellitus in a controlled state are not the contraindications. Okay, keep this point in mind. Now, after this, let's see a few important direct MCQs. Okay, direct single line kind of questions. What's the predominant estrogen found in a menopausal woman? In a menopausal woman, estrogens are coming down, yes, but there are different types of estrogens, right? E1, E2, E3. Out of all, what's the most predominant estrogen in a menopausal woman? It's the E1 estrone. Okay, estrone, estrone. From where exactly this estrogen is coming, guys? Estrone is coming, guys. Her adrenals are still functioning, right? Yes. These adrenals are going to make androgens. These androgens are going to the fat tissue, adipose tissue, where they are peripherally getting aromatized to weaker estrogens known as estrone. So, estrone is a predominant estrogen. Now, in a postmenopausal woman. Now, other special conditions where HRT can be given. In which conditions HRT can be given? Yes, you can give it to menopausal women who have hot flashes, yes, who have this osteoporosis and all, but special conditions. Premature ovarian failure, yes, if a female have premature ovarian failure, she is in her 30s and her ovaries stop functioning. There is no source of estrogens in this 30-year-old woman. So what you can do? You can replace the estrogens. Why? Because if you are not replacing means she will have osteoporosis. She will start to have these hot flashes, or she will start to have atrophy of the genitourinary system. So, premature ovarian failure you can use. Or I can simply say, wherever estrogens are needed, in all those conditions, you should replace the estrogens by hormone replacement therapy. Who needs? A woman with premature ovarian failure needs estrogens, true. A woman who have undergone oophorectomy. Okay, there is this female of 30 years old. Now, because of some endometrial cancer or ovarian cancer, there was this hysterectomy along with bilateral salpingo oophorectomy. You have removed her ovaries. Now, still she is 25 or 30. Then you have to replace the estrogens. Or there is this woman where by birth her ovaries are not functioning. Gonadal dysgenesis. Example is Turner female. So, for this Turner female who is not producing estrogens, you can simply give estrogens to this female. Or in special conditions like androgen insensitivity syndrome. Guys, androgen insensitivity syndrome we have discussed in the topic of intersex. You have to remove the intra-abdominal testes. Now these testes, intra-abdominal testes, are producing the testosterone, and this testosterone is getting converted to estrogens, and these estrogens are responsible for the breast development in a androgen insensitivity syndrome female. But we also know These intra-abdominal testes, they are at a risk of developing gonadoblastoma and dysgerminoma. So what we will do in AIS, androgen insensitivity syndrome, we will remove this intra-abdominal testis. We will remove. Whenever you remove this intra-abdominal testis, you have totally knocked out the source for estrogens. Now estrogens are lost. Now what you have to do? You have to give estrogens to this female to prevent her from osteoporosis. So there are certain special conditions where estrogens or a hormone replacement therapy is indicated. What are they? Turner syndrome, androgen insensitivity syndrome, a female who have undergone oophorectomy, and a female who have undergone a premature ovarian failure. True. Okay, well, now after this, let's talk about breast cancer after hormone replacement therapy. We all know taking hormone replacement therapy increases the risk of breast cancer. Okay, if at all there is a breast cancer, is it a good breast cancer or bad breast cancer? What does I mean by? Will there be a good prognosis or not? Is it a more malignant variant or less malignant variant? It's a good malignant, it's a less malignant kind of cancer you will get after hormone replacement therapy. Whatever the breast cancer is coming, it is low grade, and less malignant. But that's what I mean by. And also you have to know some more important points. Please concentrate here. It's a low grade cancer and it's having a good prognosis. Along with that, see, after taking this hormone replacement therapy, the risk of breast cancer does not increase up to 3 years. Okay, after taking HRT, the risk of breast cancer is not going to increase up to 3 years. Or if you are taking estrogen alone, okay, estrogen alone, not progesterone, if you are taking simply only estrogens, the risk does not increase up to 5 years. Okay, these are some important points about the breast cancer after HRT. Now, after this, a very important question. There is this woman of menopausal age group. Now, she had this amenorrhea for 6 months. There is this menopausal woman. We are not saying she is into menopause, but her age is saying that she is near to her menopause. Now, menopausal age group woman, she had only 6 months of amenorrhea. According to definition, to say that she is completely into her menopause, she need to have 12 months of amenorrhea, but she have only 6 months of amenorrhea and starts to bleed. Menopausal age group woman plus, now she is bleeding, she had amenorrhea only for 6 months. Now this bleeding should be investigated as, now we have to take this case as post-menopausal bleeding. Even though according to the definition, she is not fitted into the menopause, according to definition, she needs to have 12 months of amenorrhea. But still, with 6 months amenorrhea, we are going to consider this bleeding as post-menopausal bleeding. So they can ask you a question something like this. To say post-menopausal bleeding, how many months of amenorrhea she should have? 6 months is enough. Okay, so that's one important point I want you to remember. Other than this, please concentrate here. This MH3 is nothing but the hormone replacement therapy, menopausal hormonal therapy. Okay, menopausal hormonal therapy is not indicated for the prevention of coronary heart disease. Yes, MCQ. We all know that when a female attains her menopause, there is a risk of coronary artery disease. To prevent that coronary artery disease, are we giving HRT? No, we are not giving the HRT, MCQ. Now, a very important question, my favorite question. There is this post-menopausal woman. Yes, menopause attained. Now she starts to bleed. Okay. We have performed ultrasonography. On doing ultrasonography, the endometrial thickness came to be 9 mm. What is the next step to be done? Post-menopausal woman, we have done the ultrasonography. On ultrasonography, it's 9 mm thickness. Okay, she's bleeding. That's the reason why we have done the ultrasonography. It's 9 mm thickness. And what is the next step to be done? Guys, important point to be noted here is that after menopause, the endometrial thickness should never exceed 4 millimeters. Some books says 5 millimeters. Usually it is 4 to 5. Okay, endometrial thickness should never exceed 4 millimeters. In a postmenopausal woman, endometrial thickness should not exceed 4 millimeters. If it is more than 4 millimeters, now in our case, if it's more than 4 millimeters, what we have to do is simply take out that endometrium, okay, by rather than by curettage. It's better to do by hysteroscopic, okay, endometrial biopsy. If at all there is some polyp or whatever, you can know it. If you are simply doing blind curettage, it's not that good. Do put a camera inside uterus, that's a hysteroscopy, and you take the biopsy of the endometrium. So hysteroscopic endometrial biopsy is needed, and this biopsy is sent to the histopathological examination. So this is the next best step to be done. Okay guys, I have completed all the important topics which are needed for your exams. Hope the topic is helpful. Thank you.